January. The year-to-date position at that juncture of deficit 1.2 million. That was £400,000 better than planned, with a run rate favourable at £500,000 a month. That is the run rate we now expect to see broadly through to the end of the year.
The session commenced with confirmation of the previous meeting's minutes, which were unanimously approved. The board then proceeded to review the current financial standing of the trust, highlighting a stable fiscal outlook. Key financial reports underscored prudent resource management and identified areas for continued efficiency. Strategic priorities were assessed, with the board emphasising progress on service delivery improvements. Updates on ongoing initiatives included advancements in digital integration, enhanced patient and client experience, and workforce development. These reports reflected both achievements and ongoing challenges, underscoring the board's commitment to continuous improvement. Governance matters were then addressed. Key policies and compliance requirements were reviewed, with discussions centred on ensuring the organisation meets regulatory standards. Risk assurance processes were evaluated, confirming a proactive approach in addressing potential challenges. The meeting also included public questions, allowing stakeholders to voice concerns and pose inquiries. The board responded with openness, reinforcing their dedication to public engagement and transparency. In conclusion, the board approved a set of actions and outlined the next steps for the upcoming quarter. This included review schedules for follow-up on projects, continued focus on key performance indicators, and preparations for future meetings. Through these proceedings, the Trust Board reaffirmed its commitment to responsible stewardship, effective governance, and transparent communication with the community it serves.
Taking into account what Jonathan was just mentioned in terms of escalation and increased activity, we actually see temporary staffing costs as a percentage of pay bill come down for a third month, which is really positive news. Turnover is also at the lowest point recorded over the previous 12 months, which is really positive. It shows stability in the workforce and particularly some of those high areas of turnover. So HCA workers are starting to see that stabilise now. Did also want to point out vacancy rates because of our particular programmes of work, particularly around pharmacy areas where we have historically had really high vacancy rates. So we can start to see that come down through the dashboard, and you'll see that in the additional professional scientific area of the dashboard where we're seeing those improvements. We do still have stubborn areas, so particularly AHPs and in our therapies, we do have quite dedicated programmes of work looking at things like over-recruitment, things like reducing turnover in those areas, and we've now seen always the recruitment of a AHP lead within the organisation to take forward that agenda for the workforce. Just a couple of areas of watch for the board. I have mentioned previously sickness absence. We know, of course, that this contributes towards our not rating as well as segmentation. For us, we've been doing a lot of work around long-term absence because that's one of the areas we've seen that increase. That has reduced quite considerably, and you'll see that in the dashboard. So the in-month absence for long-term sickness has come down by 0.8%. So almost a full percentage mark. However, because we've been going through those winter months, short-term must offset that. We remain at about 1.96%, which is high for us, but it does fluctuate throughout the year. So I do think we were expecting that short-term sickness to rise. So just like we were able to bring that long-term sickness to contribute to that. Also, looking at formal cases, we've got a very brief description in here around formal cases and particularly disciplinaries. We have certainly seen over the last 12 months several programmes of work that we've had underway around compliance, so whether it be sexual safety at work, whether it be the anti-racism programme, which is very much underway and ongoing, but also policy compliance, so things like information governance. There's a big piece of work around this in the organisation. So inevitably, because of that, that scrutiny over that compliance, we do see the formal cases around disciplinary increase. So just want to store that out because looking at the dashboard, that does show that increase quite starkly. I'll stop there. Yes.
Thanks, Catherine. What do you mean by time to harm? What's that measuring? Is that from when you put the advert out to signing a contract with somebody?
So
or what?
the time to hire that we show in here is the point at which we put the advert out to a start date being agreed. So once we have a start date agreed, because then, you know, we have notice periods, we have a variety of things that then.
So there might be 2 or 3 months after that.
But once we've got that start date agreed, we know when somebody's coming in. Effectively, the process that we can conduct is you know, it's running its course.
Yeah.
We do have it in sections, so we can analyse by each part, so how many the advert part takes, how many shortlisting, how many interview to offer. So we do break it down through those different lenses.
But as we go into next year, we're looking for efficiencies. There's a lot, you know, we don't want to sort of say AI all the time, but there, you know, these kind of core processes, which are often high volume, low complexity. We really look at how we kind of, you know, speed up, charge through that, because you can, you know, quite quickly lose. And we're doing a lot of agency, but just something that to look at.
But building on that, where I've got lengthier times 5, particularly groups. So are we doing anything to else to
Yeah, it's a really good question, and I think for you know, it's quite difficult to think, particularly people are waiting for things like qualifications to come into place. So people have been made an offer, but we need to wait for that qualifications problem. We are launching in April an applicant dashboard. So once people have their, once they've got their unconditional offer, they will have a dashboard that basically gives them an online induction into the organisation, and will kickstart things like some of our mandatory staff training, so that they can start to get on with that before they come into the organisation. They'll have a welcome from executive board members as well. So they'll become familiar with the organisation, they'll get to see things like policies, get to see updates from the organisation. So it tries to bring them in at that earlier point, even though they're some of my.
It's already here, Catherine, I think you mentioned us trying to keep working at those stubborn recruits, because we know we can't fix the ability to get the team to focus on. Thank you very much. I shall move on to the nursing workforce update, please, Marcia.
Okay, the report is read and it's highlighted 2 points in the team, providing assurance. Continue to strengthen the governance process around our rest time, and ensuring that we have safe staffing to do so. The report will flag that we've had 228 red flags released across adult and pediatric patient areas. And 141 of them we were not able to fully mitigate them, but there's a caveat in this around data cleansing, because our matrons and our ward managers do go into the numbers, and we have been reflecting that. So that's piece of work you can see we've noted that there. Workforce utilization suggests that we have 12 areas that are exceeding 110 to meet needs of the patient. However, looking at the data with some of the quality indicators, there's no direct correlation to staff utilization and patient safety currently. And for the board assurance, we do monitor this in more details at ward performance level, looking at each ward's indicators for assurance. Yeah. The other bits to note are fill rates are better at night than during daytime, and that allows us to utilize our senior nurses and midwifery staff to move forward. So those are the key points. The final point to note, we've had an increase in agency usage for registered staff in December, but most of those you would have seen were for registered mental health nursing. And the national program that we're part of, the Enhanced Therapeutic Observation Care Program, that continues. So I'm anticipating over time we will see a reduction. However, the complexity of our patient profile that we've seen recently doesn't really help the picture, because of the nature of that. I'll pause there should there be any questions.
Marsha, Darren, for you or for Catherine, I just kind of mind an update on healthcare assistants, because I know it's been a topic that's come up when we've looked at grading before, and you know, the proximity of other employees suppliers in the area, and Amazon are moving out to Milton Keynes and things like that. Just wondered where are we on that? So a quick update on healthcare assistance and whether we're as concerned and whether we're an attractive employer.
I will start and defer to Catherine because our model for support workers have changed to nursing ratio. We've increased our nurses because the evidence is telling us that it improves quality of care, patient outcomes.
Okay.
So the need that we would need has reduced, and I'll now hand over to Catherine to further elaborate on that.
And with the healthcare support worker roles that we have, as I've just touched on, we're seeing reduced turnover in that. Suggests it's much more stable than it has been historically. I think one has been a call, but since we've been through the exercise of moving from band two to three, and actually all of our healthcare assistants, pretty much all of our healthcare assistants come in or will be a three after they've been through their period, their first few months too. That seems to have contributed to that stability also, and also those market factors that were extended to the system.
Yeah, thank you.
And yeah, Marsha, I just wondered which wards specifically were above safe thresholds and what board level support might be useful to help address that.
Safe threshold.
Yeah, you said about board safe staffing.
Are you talking about the staff utilization?
Yes.
So those areas that have, there are a few, if you go down to the next slide, on the report, it shows you the areas that would have had high staff utilization with the indicators that run across. So the ones that were growing red were wards 3, 15, quite a few of them, but take into consideration the governance around that. So we have safer staffing meetings 3 times a day where staff are deployed based on complexity of the patient profile. And that's where the ward managers go into numbers and the matrons go into numbers. Corporate nursing teams also go out to help based on the acuity.
So if I come in and say, Marsha's absolutely right. We'll say where we appear in the report not to have sufficient numbers, we have we have the appropriate number of senior nurses who are supernumerary that we can deploy, and or we may have other band 5, band 6 nurses in the organisation in other parts that we can move and redeploy as well. So the report is action such that it shows us where the problem is, and then we mitigate it with those supernumerary staff.
And sorry, how sustainable is that? Those mitigations?
So you may recall when I said at the beginning that the red flags, some of them are unresolved, and we've realized that their data cleansing is bad. Regarding the sustainability, we have a part of the Safer Care Nursing tool. You have to do a reassessment, look by annual establishment reviews twice a year. So we're in the data capture. So we'll go through that, looking at all the quality indicators, staff utilization, and if there's a need that we'll need further staff, that's where the business case will come through for further investments.
And just to give the board a sense of that further investment, this year in the organisation, we've invested well over £1 million in additional nursing posts because we've established that where there are consistent themes, we then do business cases to put the additional staff in.
And
it's much sure we have to remove the agencies for mental health. We are confident that we are able to remain below the national guideline for our rates.
So we do work within CAP, within our agency, and when we don't have any on framework, agency. So we are, it is a small amount. Our agency is reduced fairly dramatically. But this is one of those areas where it really is dependent on that very urgent need and escalation areas as well. So I think it's tricky.
I suppose just for further assurance, you've picked up in the report around that we've had 47 nurses that have started from the latter part of this year into this year. So they're going through their induction process of trying to get numbers. Yeah.
Those questions. I'm staying with you, I think, Marcia, for the maternity incentive scheme.
Yes, I've made reference to it in
Yes,
the
you
last
did earlier,
report.
yes.
Basically just capturing that we are fully compliant, the area of risk for us to make sure we sustain the improvements that we've seen. It's around diabetes to maintain our position going forward next year. And to confirm that we have submitted, made our declarations to NHS resolution, and we've got the receipt back to confirm receipts.
I think it's excellent that you have remained compliant with 10 years. Thank you very much for that. I'll move on to the integrated quality report. I'm going to go to Kate.
Thank you very much. This is a report that contains lots of different areas, mainly related to but I'll start with the health and safety quarterly report. We've discussed most of these actually in other committees, so all members sort of have a chance to look at some of the data already. So health and safety, we've got a fully established health and safety team. It's working under Kemi. It's a really proactive team. They're really out and about the organisation and across sites as well. So they've done multiple visits across both clinical departments and also places like Lloyd's Hall, CDC in response to incidents being raised. So really proactive work going on. You'll see from the kind of headline pages on the cover sheet that although actually overall there's been a decrease in health safety reporting, the no major orchestral harm incidents, one low harm reported incidents, that violence and abuse surprisingly remains our highest reporting category. The hotspot areas remain largely the same. That's really down to the patient demographic on those different wards. So there are D, as you might imagine, on wards who actually predominantly with patients with dementia or who are otherwise complex. Happy to sort of take that one to the report as well. There's quite a lot in there around compliance, around ongoing work, and around the work the team are doing around all these different areas. I mean, violence and abuse, I think, remains our biggest area of focus. Marcia and I particularly spent a lot of time involved in that work, and also supporting staff in the wake of incidents. What is really positive, we launched, you'll be aware, we launched on Cabal a few months ago, and we've got several active police inquiries ongoing at the moment around incidents here. So we are seeing those prosecutions and that police intervention strengthen. We're also picking up really important learning around pathways. There's lots of crossover with other patient safety related incidents where we people to collaborative with different teams around safe and wider staff safety. Health and safety.
Oh, thank you, Kate. We talked previously about the violence and abuse, taking out the dementia, cognitively impaired cohort, so that give us a more representative picture of normal inverted commas behaviour. Is that, I couldn't find it in the detail, I don't know if that's, and maybe it's onerous to record.
It's not, we have recorded it before. It's about 50-50. So I think it is on page 19, I think 72. So it's a bit, it's in this cohort reporting, it's a little bit that's 43% of patients who have been assessed as something who've got to impairment and 50% who haven't. That data is not going to be super reliable because it may be that patient's only just come in, hasn't had a capacity assessment, and so it won't be entirely reliable. But that split between that 50-50 roughly split has been fairly consistent in our reporting.
And is it helpful to you to record it over time?
It will be, it will be, and we'll have to do some analysis and review about how accurate it is.
Yeah.
So we'll do some audit based on it once we've got a reasonable database. The other thing to mention to us, health and safety, is a nursing team have seconded a senior nurse for 3 months to focus on the care-related elements of violence and abuse. So the things, the ward environment, the care interactions that may be a trigger for personal care, for example, that may be a trigger for more violent or abusive behaviour. So that's really, really positive. And again, just that we're working really holistically in this space. It's a really positive progress seen.
If you say there's all in there, isn't there? So maybe you need to
Look in the health and safety report, and then
year we could perhaps pull out some
Yeah.
seminar done.
and then QI, positive news in QI, around some of the work they've been doing with the coaching work, the improvement academy. They're working hard on things like quality accounts. There's lots of large scale quality improvement programs that are ongoing across the organisation and have very positive results. QI team are involved in a lot of work related to sepsis and also to market reform. You'll see the theme that was noted in the patient safety report around overdue incidents is also mirrored in here around the general compliance. So things like nice baseline assessments and some of the audit compliance. I think it's reflective of a busy organisation where this work is not, it has to be balanced between other priorities. However, we are looking at how we are structured in our central teams to provide that support in leave some of that burden potentially away from teams. We won't be able to do it entirely, just for obvious reasons, legal audit is led by commissions. But there's things we do to support that more effectively. But it's a really great work in QI, which I hope is evident through this report.
I attended the recent what do we call it, graduation of the quality improvement projects. And the thing that shone in the room was support they get from the QI team, but also how they support each other. They're all very different parts of the trust doing very different projects, but the passion for improvement just shines through. So it's very positive.
Very positive, yeah, absolutely. On complaints of PALS, I mean, again, I think the numbers really speak for themselves. It's a very, very busy department. We've been pleased to have the PALS team reopen their drop-in service. And so for a while that wasn't able to be open because of staffing issues, but also because of volume. The staffing issues have been resolved, and that team is now offering that face-to-face drop-in service, as they went before, and dealing with them. They are a very busy department, dealing with lots of cases day to day. As is complaints, so as I've mentioned before, complaints volume is increasing and complexity is increasing quite significantly. We're seeing a lot of AI used in complaint submissions, and which obviously gives us, a challenging job to do in picking, where a legal case begins and where a complaint ends, and the integration between the two, the interface between the two. We've had some areas where complaints response times aren't where we want them to be, and there's dedicated work going on in those different areas to improve those. But actually, overall response times are improving despite the volume and complexity. And we've got a good new process around divisional ownership and accountability, which has improved both the quality of the complaint responses and the response times. A couple of inquiries ongoing with PHSO, which I've reported previously. PHSO work does take time. They are very thorough and methodical in their approach, so we're working closely with them. Patient experience, I won't labour particularly. It's, as always, it's a lovely report to read. There's lots of positive work going on. There's a couple of areas that I just want to pick out around linking some improvement work. There's a lot of work going on between QI and patient experience in the ED. So working with the members of the ED team around the ED environment and also some pathways. So early pregnancy loss being one of the ED we've seen as a theme emerging through complaints around people's poor experience arriving in ED with pregnancy loss. So how we improve that experience and ensure that they those people get the care they need the right place and as quickly as possible. We've had a little bit with the PET platform, so which you'll see the data in the PET platform, but they've had some problems internationally with their platform, which has given us a bit of data disruption. So I hope you see that level out next reporting period. They're not entirely sure what's caused that, but it's not only us, it's affected with everywhere. So they're working out it for litigation, very briefly, we've had some good feedback from the forest office around statements, very positive doctor statements, which is nice to see, and some ongoing work around safety alerts. So work Marsha's been leading around some non-compliant personal protective equipment, which is around a safety alert around sort of code change, and we're quite confident that work's being resolved at the moment to ensure that protective equipment that's the equivalent of that's hoods, so not face masks. And we're doing some work around following a particular event that may or may not go to request, but we're doing some learning around attendance in ET, where we're looking at the provision of pre-attendance payment forms, so where you might not be entitled to have your entire NHS care funded, but for the interaction in ED and the interface between patients and the emergency department, and just looking at balance of risk and requirements for that. Any questions on that? Whereas risk management is as it says, really. There was reported here some obvious housekeeping that again continues about risks that are really due, but all works incredibly hard with the divisions to ensure that those risks are reviewed, and we've approved at tech the emergency planning risk onto the corporate risk register. So the board doesn't need to approve that, it was approved at tech prior to reaching the board. And then information governance, really good progress. So you'll remember the board over last year that we had some concerns around the data protection and security toolkits and our compliance around some areas of the toolkits. This year is a very different picture. It's incredibly positive, working really well between IT and IG. Our early baseline assessments against the DPS team are really positive. So we are confident at this time that we've had all compliance with the toolkits, which is where we would expect to be, barring some strange anomaly in. There's a risk here that around removal of mandatory training from induction. We've reinstated mandatory training in the intervening period of this paper being written to arriving at board. So that risk has resolved. So we've reintroduced. It's always been mandatory training. It's always been existed in the induction, but it's now a face-to-face training module for induction, so that we can manage risk appropriately for new starters. So that is just increasing people's knowledge and awareness of information governance requirements as they join the organisation. Every member of staff is required to complete annual mandatory training of information governance anyway. It just makes sure that we start well with our staff. And then there's some work in here which was expected to be to give a particular view on that, really around how we manage some of our systems and looking at tech to improve how we manage things like subject requests and requests for information that come from different regulatory ones. So, really, thank you.
Yes. I'm not sure anyone's going to have any questions, because the report probably answers itself in that sense. But
and it does all go through the committee as well.
Yes,
so
I was going to say, we discussed this in other places in terms of some of the detail coming up through different committees and different meetings. Yeah. Thank you. I'm not seeing any hands go up. So thank you very much, Kate. I'm going to move you on, I think, to the risk management report and then the board assurance framework. So I'll go to yourself again.
So the risk management report, as per the previous report, really, we've had what's overdue risks. Those are being actively reviewed, because some of them are well overdue. So the ones that are well overdue, I will leave them just go this can make traction in the longer reads to move those along. As I said, the board, the trust executive committee has made the approvals necessary onto the board with registers. The board aren't being able to do that, it's just here for reporting purposes. And the board assurance framework, again, this goes through committee. We obviously did some work around board assurance and our likely risk profile for the new financial year in a seminar last month. So we are coming to the close of this back, if you like. So we will start this move towards the new back requirements.
Yes, so the board can note that we've had that discussion in February for the year, but we'll start in April. But this is completing the year of 25-26. Any questions? Thank you very much. Yes, thank you. In the pack are the board committee assurance reports. I'm going to take them because they are from note from the audit and risk committee, charitable funds, and the finance committee, people committee, and quality committee. So they're all here, aren't they, this month? Is there anything anybody wants to ask or raise?
Yes, I just wanted to
the board's attention to the recommendation from the People and Culture Committee. They've escalated to board for an approval to amend the three pathways to realign with the wireless. And that was approved at the committee because I chaired. He was approved for recommended for the board. Have people got sight of that in the back? It's on this. I'm looking at people's faces and thinking people may not know they're going to be asked for approval, so they may need to give you approval looking at people's faces by email. Sarah was at the committee meeting. I can't think, but you were at the committee with me, so we've seen it there and supported it. If remaining members would like to email to Kelly and they've read it, that would be helpful. It's a very short document amending the BAF HR BAF methods because of the way that we've journeyed and what we're transitioning into managing over the coming year. That's really the summary. So is that, are you happy that we did that like what you need? Because I can see I was about to put people under pressure there. Use of corporate seal.
Yes, so obviously this has been to the board for approval. It's quite a long list this time actually of the times the sealing been used. But mainly for building states work a lot entirely as other contracts as well. So nothing too surprising on there, I don't think. And if it was the case, I would to signatories.
Thank you very much. And we'll move this into final parts of the meeting. So we have the forward agenda planner. So anything that we wanted to note or comment on that, I haven't got anything there. We move into the new financial year. Notes, so that's noted as well. And we have got, I think, we have one written question which we've provided by email. We have another written question. Yes, so I'm going to ask you to read. Is this? Oh, well, the gentleman said, I thought there was another written. We've responded to that. We've responded to that.
Yes,
so this is the second one we received this morning.
I'll read it myself.
I'm happy for you to read it yourself if we're happy. Yes.
I've been thinking about it during the meeting, so I'll make it short. I'm here to provide a final statement as a volunteer rental. Now, any shop is welcome when you've been in hospital for a while. At moment, very reluctant to listening to promoting. We're allowed to choose at moment in all the parents who are shopping free. That's the case for the shop. What the League of Friends provides with our independence for volunteers. Got the freedom, time to talk, time to respond to what patients, staff, and visitors need, which contracts just uploads to share, which you can't with a commercial holding chain context of that freedom. I removed Jeremy Folk. This is another reason to have a shop in school. Our chair, Hill, arranged this to provide the only open stack. Don't be switched to always like some rice, pasta, most importantly, toilets. Very difficult time when you're going to get this thing in the shop. Working in hospital, you might have the time to get the shop. It's also restarted our online board delivery service. So if you're isolated on board, putting an order, get your relatives to the and local goodies, just those moments of the press it will make a huge difference, which was always disappointing to learn that shop was possibly worth statements. Now closed to make space for extended to people to understand. Understand there's commercial realities, practical considerations, possibly growing, it is growing. I will note that the shop is also TV. I can't have to create such a restaurant. I understand we finance refurbishing to the shared seating area. It's a happy relationship. Once more, I think so. We're about to say, yeah, I get 10. The hospital was recently public planning application, December 2025. Rather than sending a single scheme, with their options, show that the MK French shop will keep new reflection. Jason restaurant. That's true. That's best helping for everyone. And if not, I'm also been involved with Lecture League Friends for social hospital, the original hospital for the hospital. Lost our shop on site some years ago. Once charity loses the on-site presence. The others in site are less in the one day, but obviously that makes a huge difference. I'm not here to ask the board to say that shops are not going to close. I understand there's no obligation for public consultation, but I'm asking if there are considerable shops available by having that public consultation so that they can make an informed decision about the future of the front shop.
We'll leave the conversation outside of the meeting with Kate. Kate, I'm going to ask you to stand here in the meeting. I'm sorry.
Yes, I'll take it. So what we will do is respond in writing. I think a couple of points to note. One is that there's no question the organisation has been grateful for the friends and the work that has been put in over the years for the hospital. I think there's also no question at all that the current restaurant facilities that have been in place for the last 30 or so years absolutely need expanding, and we are not surprisingly now getting concerns raised by members of staff that actually they can't get served in an appropriate time for their lunch break because of the queues in the restaurant. So the options appraisal that took place in April, May of last year considered how best to really provide services. And what we've been doing since we received the query sort of formally this morning, because I know there were issues around us getting the query through, is tracking back to understand what the planning implication says and how that fits with the designs internally in the organisation. Interesting, the planning application does not have to specify, as we understand it, what is incorporated within the walls of the organisation in the restaurant redesign, but it does have to specify where the external walls are changing and what is being made of and so on. So I think what's happened is that the options appraisal about how to provide the maximum amount of additional space for people to get their lunch and get fed watered has not kept pace. That option appraisal has not kept pace with the designs in the planning. But we'll respond formally on that. I think it's important for everybody to note that we have made a commitment in line with our values that what is being provided from the food and beverage perspective is going to be made available on site for both staff and patients, carers and families. In addition to that, we've made a commitment that the trolley service that is extremely valued by our patients, families and carers on wards will be provided. And I believe that we have already purchased a new trolley, or at least ordered a new trolley, to ensure that we have got everything available to take around. So we'll do a formal written response, but I think those are the headlines from what we've done since this morning.
We will respond to you with a written response simply in here what it is. Obviously, I know that there's appeared to be a difficulty of getting that, to us, not from your perspective, but from before the meeting. So but I'd like again to thank you for volunteering, because I know how much volunteers do bring to organisations having worked in charity, and we absolutely want to make sure that the things that patients and families and staff access, as Joe said, can continue in the best way. And we have had government involved in the conversation around the trolley and enhancing indeed that trolley experience going forward. But we will write to you in relation to the questions that you've asked. Thank you. And thank you for waiting, for introducing to us, Kristen. I'm going to move a motion to close the meeting at this point. Thank everybody online who's been listening, and thank everyone in the room. And for those people who are moving, will be moving into the private meeting, just to be noted, I think we're going to have a 2-minute loo break, but we're going to move into the private meeting straight away from here, as opposed to waiting until whatever normal time it is, 12:30 or 1 o'clock. Thank you very much, everybody. Thank you.
It would take
We're going to restart. Everybody got what they need? Yeah, fine, yeah. Okay, everyone, we're going to start again. Right, so moving on to our performance section of the agenda, and the integrated performance report, please. I'm looking at you.
That's me out. Okay, so I think, as Joe has alluded to, we had very positive end of year position, both planned and unplanned care, and I think there was some in the planned space, there was some additional funding that became available that we worked on in Q4. In the unplanned space, we funded a very small amount internally. There was no external funding, but we had lots and lots of focus on it. So really great to see that we ended ahead of our 62-week position. So we were at 62.6. We did see a significant improvement in the number of patients waiting over 52 weeks, but I will just have to still flag we were at 2.6%, which was better than our submitted plan of 3%. However, still not in line with the plan guidance, which would have been 1%. So we are becoming a bit of an outlier now in terms of 52 weeks. What is not reported here, because technically it should be 0, is our 65-week position. And we just had at the end of March a small handful. We were in single digits for the number of 65 weeks that we reported, and our diagnostic performance was good. The report here points out an improvement in our cancer performance at 62 days as well. Just to remind people, I have said this before, as we treat our backlog of cancer patients, the recorded performance does deteriorate because just the way that this metric is measured. So we will start to see that dip as we continue to treat that backlog of patients. Unfortunately, because, and I'm sure we will discuss this more later, we are still in a kind of no man's land in terms of our contract position. We took the decision to maintain some activity that we could during April, but not at those levels, and therefore we are already starting to see some impact of that, and you'll see that as it plays through. In terms of unplanned care, we also, sorry,
so just
yeah,
just on the contract position, I'm conscious that we've been having really positive and helpful conversations with our RSCP. We haven't quite signed everything on this yet, but expectation is that we will get there over the next sort of week or so. So just a bit. Sorry.
Yeah. Okay, and the sooner we get, we're all aware, the sooner we get that decision, better, because the longer we delay, our position deteriorates, and then it's a bigger hill to climb. But really great to get to where we got to. In terms of our unplanned performance, so our ED performance, again, we finished at the end of March in a really good place. Significant improvement on our February performance. We finished in terms of 4 hours at 79.3. However, again, and this isn't a funding issue, but we got to the end of March and were immediately hit by both junior doctor strike, the Easter holidays, and the need to close some of our escalation capacity. So we have not seen that March performance maintained, but we're working really hard now to reset that and to try to improve that as we come through. But the April data will not show you that maintained performance as we move through. I'm very happy to take any question. The only other one that I didn't mention was diagnostics, which again, end of year, really, really positive performance. The area that I talked to you a lot about is audiology. That is the major modality that we struggle with. I'm really pleased to report we've got some capital funding in the next month. We will see the completion of an additional audiology booth to increase our capacity, and there is a case coming through that should be cost neutral to see whether we can manage some additional staff through that area. So that's positive news on the audiology front, which is the outstanding big diagnostic area of concern. It's
Well, I just think because this is public forum, just to say congratulations to everybody, particularly on the 18 weeks. That's a massive improvement year on year, and even the last few months. So I think that should just be put on that vote. That's really, really good. I think then that flips into the new year, which is to say, nothing so crass as we've got to keep it up. But if it then starts to dip, it becomes immediately harder, because this year's target obviously trajectory is going to get higher. So I know contract negotiation is one thing that can be sort of maybe take a bit of, I won't take the foot off the pedal too much. And if there's been finance behind some of it, just even the small differences there, then means you've got another hill to climb rather than continuing on the change trajectory. So how do we balance that? Yes.
So it's absolutely a challenge. As I sit here now, the team are doing the week meeting, so there is still absolute focus on going through that. And for the longest waiting patients, that happens line by line. The overachievement in March is helpful for us in some ways, because our submitted plan assumed that we would achieve 60.5. So it has given us a little bit of headroom in terms of delivery of the plan. Although I hear the message, we don't want to see any deterioration, but we finished 2 and a bit % above the plan. So we've got that little bit of early headroom to help us a little bit.
A couple of things. We talk about our waiting times quite rightly as an organisation, and saying that we're at 60+%, so more than 6 out of 10 patients being treated within 18 weeks. I think it's important for the board to note that there are significant numbers of specialties that are performing well in excess of our national position. So, for example, if you're waiting for a dermatology, more than 9 out of 10 people are seen within 18 weeks. And there are about 2/3 of our specialties are seeing and treating the patients within 18 weeks. What we're seeing is some real high pressure areas: orthopedics, gynecology, ENT, where we have both a longer than we would like waiting time for outpatients, as well as a longer than we would like waiting time for an inpatient or day case operation. So absolutely hear what you say about trying to maintain. I think it's important that we as an organisation look at improving those specialties with the longest waiting times wherever we can, as well as maintaining and improving those that are already seeing general medicine, gastroenterology, all of those, more than 9 out of 10 people went in within 18 months. But it's a fine balance, and Helen and team do a brilliant job of getting into that real micro level of management, trying to make sure patients are.
And I guess just to be very clear on that, so that's really, really helpful. But obviously, trauma and orthopedics is where it then turns into a procedure where it's meant to be other things will be outpatient only or regular. So, but that's then where the money and cash becomes particularly important in its high volume as well.
It is. I mean, again, I suppose it's interesting for the board to note that around about 3/4 of the entire waiting list for a hospital is waiting for an outpatient work. And so I think we have to work through, and this is what we're doing at the moment, about it would be really, really easy to hit the target and miss the appointment. And I think that's what I was trying to describe earlier. What we don't want to do is have a very small number of patients waiting for inpatient operations and have treated all of the outpatients in order to get to the national target. At the moment, we're doing everything, I think, fairly, systemically, and we want to try and continue to do that.
And I just to some of that in terms of volumes, I think it's fair to say we've had some challenges with the community MSK provider. The ICB re-tendered that service and went into a very lengthy legal challenge. However, that is all now resolved. And I've got an introductory meeting with the new provider booked, because when we look at our data, we've seen far more referrals coming directly to us that maybe should be going to that provider first. So it's been a difficult year in that respect.
I was going to ask about this, Kate. Given, like you say, the national issues we have with audiology supply recruitment, are there opportunities across the system to maybe sort of transform that?
So in terms of joint working, we have offered bits of mutual aid, even though our situation is bad, our partners in the system are worse. Our particular issue is paediatric audiology. We are quite fortunate with our head of audiology, who has an excellent reputation. So we are looking to see whether we can attract him.
And I just comment on paediatric audiology because it came up last week at the Institute, not and people are talking about audiology, but paediatric audiology across this region. So we know we're not alone in that.
Absolutely.
We're probably not probably in one of the better positions, but it is still a challenge, and it's a challenge, and it's talking about how can we work that better across the region in terms of resource.
And just to add a bit of positivity there, whilst we weren't where we would all want to be, we were ahead of plan.
Yeah.
So I think it's probably, I'm just combining those two things. I know we live in a world where clickbait headlines are wonderful. And so this situation of when we say we're bad, we're better than significant portions of the country. And I look on somebody or anyone to focus on that, when actually we're ahead of target, as you say, and we're better than the vast majority of these.
And I think to that point, though, in the conversations last week that happened in the afternoon around areas of focus or frailty across the region and where people support each other, we were very much, well, I was very much, because I was there, David, rather than yourself, but we were very much saying we obviously want to work with people where we can, but I think again it has to be made a reality, doesn't it, in terms of geography, patients, in terms of the availability of specialists in appropriate places, and where perhaps we are actually on our target, but there are providers who have significant challenge, and whether this particular issue might be almost critical in terms of how they're going to deal with it. And I think we've got to find that balance of how we where we put our focus on what we need to improve and where we help others in terms of collaborating. I think that's another dimension to how we do what we're doing.
Yeah, it's not related to performance particularly, but on the North dashboard, which is part of this item as well. So Ian and myself attended a national briefing last week, where they did an update around how that will evolve over this year. So they haven't yet published metrics for 26.7. They're due to come out during the course of May. There will be a similar number of metrics, but they will be more aligned with the 10 years plan than they currently are. They have the financial override will continue to apply for the current year, which we know during the previous financial year, one of the reasons why our rating didn't move higher than 3 points.
And also to note that no quality override has been put in. So you can be inadequate for CQC, but that doesn't automatically put in.
And just kind of along similar lines, the indications are that the tiering system will disappear. And I understand from the regional team are just putting through their government processes what it will be replaced with. So watch this space, but they're kind of when we've talked about being in tier 1 or tier 2, that won't be the future, but I don't want it to.
I think it's important for us to go on, certainly in the transformation conversation we've perhaps going to have in seminar in June around kind of what our focus is around travel the journey. But certainly I think it's really to Joe's point from planning and Jonathan, what you're talking about there. But we need to decide what we're focused on. As I go to more regional meetings and wider meetings, I can hear that topics come up that have become the flavour of the moment and are interesting, and they perhaps are very, very interesting for some providers because they are key things that need to be focused on. But I think it's important for us to decide what it is that we need to travel is as one of us to make sure we get the right improvement in the right places for patients and for our financial efficiency. So I think that's, I think, important for us to kind of hold on to as forward. Therefore, would you just make a comment on ambulance handouts, because it's a topic again that keeps sitting in the top 5 companies that we talked about, and yet our 30 minutes and 45 minutes is we particularly good percentage, I think. And yet just for some providers again, this is perhaps not something that has been so successful.
Yes, I mean, we have always wanted to do better because we all accept getting the ambulances back out on the road is the thing to do. One of the problems that Heidi and others might have is when you see regional data or you're in those forums, it's the East of England Ambulance Service, and of course our major provider is SCAS, which does make that comparative data in our system a little bit harder. But yes, our ambulance handout times are pretty good, and the team on the ground really focused on making sure we've always got an available space either in what's known as the ratting bays or whatever. Even when ED is really congested, there's always a focus to try to make sure that we can offload an ambulance.
It's just SCAS obviously go down to Hampshire and Isle of Wight, have quite a big patch. They've had historic ambulance handover challenges. They have for several years been telling us we're the best performer in that patch. One of the reasons they want to retain Milton Keynes is to improve their average performance. And just in the current context of cruise ships, the RASI bay rapid assessment.
Yes. Yes.
Yes, and I think it's important that, because I think focus on the unscheduled care coordination part of the boundary. I think it's doing very positive things, but I think again for us it's about what's appropriate here and where's our best resource. We may not want to prioritise something like that, but actually prioritising our diagnostics is going to benefit more people on their pathways. Thank you very much. Any other questions or comments on the integrated performance report? I will move us on to our finance report, Jonathan. I'm not sure we need to do roll on this.
Great, thank you.
That's my courage.
Take it in, it's fine. Okay, so this paper represents the final position as of the end of financial year 25-26, which we talked about elsewhere today and talked about in detail at last week's So I will just draw out the key headlines. So we finished the financial year effectively on a balanced break-even position. As the paper highlights, we did receive a share of the national unutilised national deficit support funding, which meant that we have reported a surplus of 3.3 million at year end. That underlying means in month 12 we had a 0.6 million surplus. You'll also see in month 12 there are a number of more significant variances at individual line element basis. As Helen said earlier, we were doing a lot more work as part of national sprint work to improve performance. So that's why you see those variances pay, non-pay income. I just will draw out efficiencies. We've hit the requirement for the year of 23.8 million, which is a really strong achievement. Capital, we fully utilised the 85 million plan, which is massive for this organisation, double which it had done in previous years. And cash, the number looks higher than usual. That's largely to do with timing differences rather than a significant improvement on cash, which remains underlying as per where we talked about before. The only other thing I will flag is the fact that NHS England have confirmed that our plan submission for 26-27 has been approved now, so there are no submission requirements for this trust. Any questions?
I mean, I don't think there's anything to share with it that you would want to. But
I would just say it's been, I think all credit to the finance team and to the operations team and everybody's put together and how we work to both hit the operational targets and financial targets. Great. Well done.
I'm not seeing any hands up, so thank you very much. Thank you, London. We'll move us on to the workforce update.
Thank you. This is our data up until the 31st of March. Happy to see the papers read. Just want to highlight three key achievements over the past 12 months. You'll note our vacancy rate is down to 5%, which is excellent, seeing as we've also had an increase in establishment through the year. Huge pieces of work that have gone on with the workforce and the divisional teams on moving agency to bank and banking to permanent. So you'll see some of the biggest wins there are in our additional professional scientific technical group, which is pharmacists, pharmacy technicians, clinical psychologists. We've gone from 17% this time last year, now 7% vacancy rate. It's a really good story for us, I think. Staff costs have also improved, so you'll see again made a further improvement as a percentage of whole-time equivalent and spend, and with the lowest point for our spend for over 5 years. Those biggest wins again are in agency. We've done some excellent pieces of work on improving variable pay, improving rostering practices, which are really starting to show through across the trust, and highlighted some key areas that we're going to be rolling as well. And finally, just 6 absence. In December, we started a really key focus piece of work on long-term absence, and we're really starting to see some of those wins now, making sure we are triangulating with our manual handling team, with our divisions, looking at themes for absence and how we can manage it, getting those on long-term sick back to work in a way that is supportive. And we've improved significantly on the last month of that, and that will be a continued focus area.
Precious, did you want to make any comments of the committee?
No, I don't think there's anything to add at this point.
Any questions or comments from anyone?
But I mean, with the time to hire, obviously that is there additional resource that you need to support it further improvement.
I think one of the biggest challenges at the moment with time to hire are the number of application forms that we're seeing through that I'm using AI to complete supporting statements. So shortlisting is becoming a real struggle for us at the moment, because you can see those supporting statements. A lot of them have got a lot of AI support, and it's really difficult to differentiate experience from what's being said in those. So that's our biggest pinch point at the moment. It's shortlisting. We're doing a lot of longer listing for our clinical managers as well. So as we move through the year, we're trying to get smarter about how we do that beginning process to have that give you time back for academic support. So, you know, it's an ongoing challenge for us, and not just us. It's a national issue.
It continues to be assured, and it's any workforce committee that focus on all the pieces of activity that we're driving against the strategy, from wide range of factors. It's very reassuring to hear the updates about that. No other comment? I'll move on to item 14 and then that's in the workforce update.
Thank you. So this paper reflects February data. It's been modified this month as my workforce leads become more established. We're just trying to provide more of assurance and an impact overview around what safe staffing looks like and what it means. I think overall the report evidences that the Trust has quite a mature and responsive safe staffing system for our clinical colleagues with quite a good grip on operational risk. Previously, I've drawn attention to the workforce utilisation metric. It did run as high as 117% on occasion. That's how hard our staff are working. And I'm really pleased to report that we are seeing a downward trend with our average now moving down to 104, which is actually now within tolerance. So that's a really positive metric for us to look at and reflect some of the investment that we put in safe staffing and the hard work we're doing around tightening up on rotas and making sure we're managing the workforce correctly. A couple of things to note, particularly around improving quality and safety outcomes. So we're seeing continued improvement in our nurse sensitive indicators, reductions in pressure ulcers, falls, medication errors compared to our previous months. And our red flags have reduced over the last 3 months, which shows more proactive management of how we're managing our staffing risks. So I think it evidences that those improvements we're making in workforce stability are now translating into better patient outcomes and safe care delivery, which is positive. We do still have workforce pressures remaining, particularly in the daytime and around healthcare support worker staffing. Daytime rates remain lower than nights, with healthcare support worker fill rates below the 90% threshold for a full month. That's partly due to the challenges we have in recruiting at that band, but also we have a lot of attrition with other work available on a better pay elsewhere in the local community. Some wards do have high utilisation and recurring red flags, and our CHPPD just does show a little bit below national benchmarks, indicating there are pressures in those areas. We're just going through our establishment review again, and those flags are coming up. We're looking at how we can mitigate some of that. I think our risks are really well understood, visible and actively managed, but it does remain a key focus for us as an organisation. So I think to sum up areas to focus on, healthcare support worker gaps, daytime staffing is a bit fragile, specific wards with recurrent pressure, so Ward 18 and Ward 5, and our sustained demand around ETOC. We are on the national programme and we're just coming up to the point where we'll be launching some initiatives to help us manage that. They are all known recognised risks with targeted oversight in place. Any questions?
I have a question about it before, because obviously we've been for January on and off. No, sorry, we've been before since January for some weeks and then off with a break. Are we currently in over or we?
We're overweighted.
I think that there was more periods of pressure in overall for organised in previous years. And you talk here about the required need for staffing flexibility.
Mm-hmm.
Does that always focus in certain areas, or does that?
No, it varies. I think operational pressure is significant, but our mitigations are strong. It's not one persistent area. It can vary from a different ward. It can go. It's influenced by patient acuity, staff sickness, but we have a good process for redeployment, and our staff are more accepting of redeployment now that it's occurring less frequently, and they understand the need why, because we've done a lot of work. So I think that we do manage the risk around that well, but it's not in any persistent area.
But when we have to do it because we are doing less.
Yeah, it's becoming more easy to manage with the staff.
Sorry.
Just so I've got about our advanced practice lead. So is that permanent or?
No, so we've got an advanced practice lead in on a secondment. She works 2 days a week. She's just scoping through our true advanced practitioners, so those who are accredited, and making sure that they're meeting the pillars, etc. And then we have our nurse practitioners underneath, and that's the next scope that she'll look at. But she's on a secondment at the moment.
So what I guess then to the wider board, what's our trust appetite to develop and grow our advanced practice workforce?
I think we recognise that there's a need to grow our advanced practice workforce. At the moment, we're still probably in a place of evidencing the benefit, which is why the scoping exercise is going on. I think once we get to that
will sort of talk with my exec colleagues around this is the benefit, this is what we can evidence, and is it an appetite that we want to move forwards looking at? I think there's lots of really positive roles out there. It's just around helping the organisation to understand where nurses and AHPs and midwives can contribute to care but not replace medical colleagues. And it's about understanding that workforce and planning for the future.
Because that's where supervision and training work.
Yeah.
Yes.
This is a really useful sheet. What are your, can you say something about the sort of tolerance limits in terms of ups and downs and pressure ulcers and medication errors? Because there's correlation between the high staff levels and medication errors. There's more reds on that greens. Clearly, some of those numbers are also going to go up.
Yeah.
Are there any lessons that you learned from that, or is this kind of within tolerance levels that you would expect?
So I think I would say, just bring it up so I'm actually looking at the sheet, that there's definitely a correlate. The reason we report it is there is a correlation between having a workforce that doesn't match your care hours per patient day, and you will see an increase in falls and pressure ulcers. There's a definite correlation there. The tricky part is matching the acuity to the workforce, because we can't predict how many patients we're going to have in that are high acuity or low acuity, and that's where we have to kind of work around it. I don't think there's anything in there that particularly flags for me. We flag areas where we see an increase in pressure ulcers, maybe by 2 or 3 in a month, because it's an area for us to watch and an area to look at and go in and make sure what's going on in that area and be concerned. I'd be more concerned if I saw an increase in falls, an increase in pressure ulcers. Louise is reporting the appraisal rates are dropping, the sickness rates going up. It's the triangulation of all that data that kind of says to us, this is a worry ward that we would worry about. So whilst we put the nurse sensitive metrics in here, we're also looking at all the other metrics as well. Yeah.
Thank you. I shall move on to item 15. Yeah, the integrated policy report.
Okay.
Thank you.
Risk is sneaked way onto the agenda twice, so I really deal with the risk over the next agenda. And it's just a brief exception report for health and safety at QI. As I sort of briefly mentioned the patient safety update, we're working on a very different style of reporting, because I recognise the reports aren't perhaps the most easy to read or engage with at all levels. So we're having a very different style of reporting into the general meeting. But just in terms of briefly items to note on health and safety, you can see that our work in violence and abuse continues. It continues to be our most reported health and safety related incident. One thing I would note when talked about it at the board before is that the number of incidents of racist abuse in the organisation are also being increasing in terms of the number that are being reported. That abuse is deeply concerning. It's very significant. It would be hate crime level of type of abuse, including anti-Semitic abuse towards our staff and patients. We're looking at developing a kind of response framework to inform instances of racist abuse, particularly because we feel that they need a different type of response, including how we support staff to potentially report where staff did the reporting, how we use other evidence to support patient reporting and action. It's a real concern, and we might be seeing more confidence in reporting, which is positive, but undoubtedly we are seeing more incidents like those every week, affecting staff in every part of the hospital. So I just wanted to highlight that here, because it's a significant piece of work. I think that there's other we have looked at the transit organisations nationally, and looking at how we can leverage some national frameworks and work in this space to help provide a consistent response across not only regions as a whole. Other work in health and safety, as highlighted, we do some work around COSH, self-compliance around substance and health register, and looking at policy gaps and areas. I think, as I've spoken about before, in the board, we've got a very proactive health and safety team who are going out about facilitation of time, doing practice assessments and looking at gaps and where we need to do policy work, we need to do working practice. And so we're seeing a lot more activity across the health and safety portfolio and then the capital report, which is really positive. And then in QI, hopefully the report speaks for itself. As ever, there's lots of detail in the QI report, but the sort of headlines are really around continued areas of compliance focus, so things like nice audit. We're looking at how we use other tools to support clinicians in this sort of space. So looking at some of our audit and documentation leads around how we might use AI to support some of our assessments and some of our documentation challenges. There's really positive work going on in QI around also some new projects that we've talked about towards the end of this document. We are looking at how we consolidate reporting, as I've spoken about, so we get these dashboard insights into different areas, and also that we can get effectiveness again, not only through a compliance lens, but through an outcome lens as well, because at the moment it's very compliance focused, moving to it to be monitoring compliance and reporting on it, but also looking at outcomes as well. Just in the point of view that the board is aware of doing all of our annual reporting on audit compliance as part of our quality accounts. So we'll have that big report coming back to the board shortly, audit particularly. We are aligning QI work with HESA areas of focus, and we've also aligned our quality accounts with those same areas. So we've got like really big push in the organisation around dedicated areas of focus for improvement. Stakeholder questions.
Okay, I think I'm just going to say that the summary format of this report is really helpful because I think there is so much in here across so many different elements that it's really important as a board that we are reported to in a way that helps us to focus appropriately. And I just want to say that it's obviously very disappointing to know that we have all this violence and aggression, but also incredibly disappointing to hear about growing numbers of reporting of racism, although actually the growing number of reporting is a good thing. That means people reporting things they weren't reporting before, but it's clearly an absolute focus for us. That's something that is totally unacceptable. Gary, I think you want to make that.
Yeah, so I echo Heidi's comments about the report. Just a question for me, which I think we may have covered before, but I might refresh on, which is the link between the level of abuse of our staff and racism and mental health issues and dementia and issues like that, and some sort of sense of whether there's a correlation or not, or whether it's just a trend that's happening in society. And just maybe not a question for now, but
so the data that we have shows that around half, always consistently around half of the reports of violence and abuse involve patients where they have some sort of cognitive impairment or their capacity is impacted in some way. So do not. And so I think we've been doing a lot of very nuanced work, and the owner's been leading work around the care environment, around how do we look at factors in the care environment that triggers violence and abuse when patients have dementia, for example. So for example, we know that personal care is often a trigger. So as a nurse lead who's looking at that around how do we provide environments that where those triggers are, we don't necessarily cause behaviour because we don't care in a way that we care for them in a way that doesn't promote their particular way they like to be cared for. We wake them up too early, and we don't talk about care, we don't advise people what we're doing, etc. But we've still got a very large portion of those instances where that isn't a factor. We have got patients with capacity who are, and as I said, it's not only in our wards where we're looking after our more vulnerable patients, it's in maternity, in our emergency department, in our wards caring for patients where capacity is not an issue. We'll be able to see violence and racism.
It's just a follow on that. I think there's a flip piece of work as well in terms of understanding how we support staff. And also just to maintain those confidence levels, because I mean, if you're on the front of where somebody's got capacity and you're facing that violence and aggression in places, and it can impact your confidence in actually carrying out the work, which then impacts our patients in. So yeah.
This is why we want to do the incident response framework. So we've got a very specific response framework for incidents of racism, because we know that absolutely, as you say, if the trauma informed response. We need to be looking at support. The P&As play a very active role actually in this supporting staff. But and we also want to be able to, well, I particularly want to be able to take a further away from police reporting staff, particularly when staff are very anxious about police reporting, and to be able to do that corporately. So there's lots of work that we are doing in that space.
Yeah, I mean, I was going to say that segues nicely back to the beginning with the role of the P&A and how they sit in the board, they support it, but also talking about that 50% who have capacity. What Shadi's finding out in some of the work she's been doing around building a toolkit to help staff is that where we become quite operationalised, we're not doing simple things like offering pain relief 20 minutes before we go in to do the wash. And so taking time to sit down and kind of work through with our staff some real basic training around, if this person is exhibiting, think about why are they exhibiting when normally they're quite calm, what specifically is going on, and check their records and understand. So I think we have some way to go around the care toolkit that we're building, and that will help with that 50% that have capacity, and we're not quite sure why those behaviours are exhibiting.
Kate, I think I'm staying with you. Going to speak up to guardian uniform. Right, yeah, yes, this is of course for previous speaker, which has been through people and culture. So I want to add this summary. So a few things to note. We obviously have a lead guardian. We have a second guardian. It's all the time between. We have previously champions who work in different areas. And we've got other sources of support staff to raise concerns like the PNAs and other sort of other more informal networks as well. So there's some work that we're doing around consolidating that resource. Obviously, you can see the figures here in terms of the type of concern and the volume of concern that's been raised. One area to note is around, it's a national theme, it's also a theme here about people being concerned about psychic detriment when they're raising concern. So one of our areas of focus is to continue to address that explicitly about, to encourage people to raise concerns about the use of confidential routes and to where they're concerned about that. Also around how we work with our HR colleagues around the different processes that people follow, how we make sure that there's parity in the approaches that are taken. So things like the fair and just panel, how those who use may or may not lucrative speaking up, and how we support our workforce to continue to raise concerns. So, freedom to speak up is never, as in every cultural use of work in the organisation, it's never kind of finished. It's always part that's going to be ongoing. And I think it's really important that we recognise that and we're continually intentional about it, because this will be work that we will do forever, about encouraging people to feel confident in speaking up and in different ways. Obviously, we've got a strong link in speaking up into our anti-racism programme. We've done lots of work with particular teams around themes around anti-racism particularly. And so there's different forums to enable staff to raise concern in different ways. Interestingly, also things like the tea trolley, the VIT trolley that's gone out during the winter, have been a really good point at which staff have been able to talk about issues that are affecting them. So although the Freedom to Speak Up report captures the formal Freedom to Speak Up reporting, I think it's part of that wider cultural network of ways that we enable and empower staff to raise concerns. But on Shah, who's our Freedom to Speak Up guardian, is a hugely positive force in the organisation, creating a really positive movement behind speaking up confidence.
Yeah, just wanted to add a bit for that, but absolutely Anna Shah has taken the role full on and just great assurance and confidence even in the committee itself. I think there's issues around the parity piece and staff feeling like they're being heard, even if it's issues around pay parity or opportunities or being able to be seen in terms of their advancement. I'm feeling confident. Something that came out of the committee itself was awareness. I think just are people aware where to raise their concerns, and there's an action that's been taken on to just find areas that are
convenient was confident, was maintaining confidentiality. So we get more reports. When we get more reports, it means that's actually working. So it's an improvement in terms of the more reports we get, the more actually dealing with the issues. One.
One of the things that the legal committee that regularly is voted through Gardner and with Harry work through Rayan, is that upskilling and enabling managers, team leaders, managers, leaders to understand or embrace the processes that exist for all manner of staff in the sector, just upskilling on colleagues ongoing about how we handle and manage. We want to hear people's voices, we want to take things through. And so again, it's probably a never ending task. It's part of the ongoing work, which I think we're doing embedding everything we do. But I certainly has taken previously, but
So just lastly, there's obviously changes to the National Guardian's Office because that function is then transitioning into the Equality Commission. So there is some change in terms of support to guardians through that network, and also the expectations of us as a trust. So I think we're very committed to Freedom to Speak Up and supporting our champions and to continue their really great work. Obviously, work on social work continues to happen, and with CPC folks as well when they start to become more involved in the space.
Thank you very much. I should move on, and I think I'm saying with you guys in terms of risk management.
Very briefly on risk management, because this is a sort of ledger report, and obviously we've again it's quite compliance focused, and we really want to be able to shift our reporting around sort of give the best way to actual sort of risk profile, which is there on the supplementary shelf, so it's forward into this report. The thing to note really for the board is we're adopting a different trading model for risk. So risk management, health and safety risk management training staff about 6 and above. So including our consultant body, this brings us in line. Well, it doesn't bring us in line, but it amalgamates all of our risk processes in line with statutory health and safety legislation, and also incorporates some of our internal audit recommendations from past years, so that we can ensure that our staff feel very well trained, competent in undertaking risk assessments. And that's important because we need to have competent managers in terms of being able to do risk assessments according to the regs, health and safety particularly, but in the broader risk environment. And I think that will improve the quality of our risk management at every level of the organisation. So that's a good piece of work that's ongoing and adopted. Last one.
Hands are up, please.
So the bank for US, our risk lead is working with execs to transition across from last year's bank to this year. Some of those workforce risks, for example, have been across, and or just in the process of meeting with executives for risk to make sure that that transition happens over the next month or so.
When is our next back updated or?
Seminar.
We can look on the 40th.
Yeah, probably not because of what we just had one, but
yes, so it's going to be a little way ahead. Yeah. Yes. Thank you. Any other questions around risk or that? Okay, so we have the board committee assurance reports. There are obviously several. And I may just point out some of the audit and risk committee report. I don't know whether committee chairs wish to make any comments at all, or whether we have some questions on anything.
Happy to take questions on you made up for this report.
Looking between the two,
I look forward
hand
to
over.
we can separate charitable funds, looking forward to discussion at that stage.
Yes. So we'll take this charitable funds and talk about that. Later on, the Finance Investment Committee, I now send me over to say that summary. People and culture we covered as well against state quite extensively, and the quality and clinical risk assurance report and just comment on
No, there's points of it, so not really big interesting.
So I moved us, but it would only move, that's not really. To the annual review of the committee effectiveness, these are here the note on them. Yes. It's just, an annual report from all the committees benchmarked against the, governance framework of the organization, just especially in terms of reference to, short walk on the problem possibly year, significant discussions and approvals made, as well as, just to ensure that everything was in line with the requirements of the client. Anything anybody wants to highlight here? Are there any questions on any of them? I won't go down the level there in front of us if there's anything you wanted to. Thank you very much. The use of the corporate seal, item 21.
Thank you. That's the opportunity here for the board's oversight and ratification. Just seals used twice in this reporting period with the contracts that are described in the
rather than get approved themselves, just stating that. Thank you very much, Kate. We've got the forward agenda planner. Again, I haven't got any comments on that. Is anything is missing or that you need to discuss that. Thank you very much. Okay, we shall move to questions from the public. We have a question from the public. Members who are actually in the room. The question is: there are at least 550 people living with Parkinson's in the Hopkins area. As Parkinson's is the fastest growing neurological condition in the world, this number will only increase. There's currently no specialty Parkinson's in the age. The overwhelming experience of people with Parkinson's at least 20 age is that their Parkinson's is often misunderstood, mismanaged, or ignored. In early 2025, the UK Parkinson's Support Group offered £360,000 for a legacy. Milton University Hospital to employ a specialist Parkinson's nurse for 5 years. The email corresponding with CEO Joe Harrison said that the board viewed this proposal extremely positively. Neurology consultants submitted business plans in order to identify and data there seems to be no progress. The 350,000 is still sitting in the support group's bank account, and NKUH is taking no visible steps towards recruiting a specialist Parkinson's nurse, and people with Parkinson's are still fighting with how they will be treated if they are admitted to the hospital. The question is, what is holding this up? And will NKUH accept the preferred £350,000? And when will NKUH begin the recruitment process for a specialist Parkinson's nurse? Thank you very much for the question. And Joe, I think you're going to answer.
Very happy to. I think we referenced earlier on the challenges with our agreeing the 2026-7 budget. I think a combination of that and changes in key personnel to bring forward the business case internally have led to delays, and many apologies for that. I'm delighted to say that we are in a position to submit a business case through internally in the organisation and then out to Parkinson's UK in the next probably 2 weeks, and we expect to go out to recruitment this month. So assuming we get an okay from Parkinson's UK. So we are absolutely moving it forward, and apologies for the delay. I think it is a combination of internal issues as well as the external environment in which we're operating.
I would only reiterate that the last 6 months have been particularly pressurised across the whole of NHS, but in NKUH and NKUH, the team focusing on what we're doing. So I think that's added to some of the pressure on some of our processes and decisions. So delighted.
I think the one thing we should also be very clearly noting is a big thank you to Parkinson's UK for such a generous allocation.
The funds come from Milton Keynes, rather than Parkinson's UK, so it's
That's right. We received a large legacy, and whilst there's most inflation has to give us their money, it was suggested that we need to provide as many people with Parkinson's as possible. So that's one of these things, like major. I know it's right out the NHS, I mean, normally, we would have done it for 2 years, we would probably need to not to.
Thank you very much. Very generous. Thank you. I have a little easier. Okay, so we're nearly toward the end of our meeting. I just want to, at the last public board meeting, I think, with President, is to thank you for everything that you've done in what was probably originally going to be your 6 months interim replacement, but has rather expanded. I really do think that you have brought so much to us as a team, as a hospital, as a trust, in terms of kind of a great foundation for team and James coming in as a go forward. So we give you our biggest thanks formally at public board meeting, but I know you're going to be a seminar when we can say goodbye properly. So thank you very much. We have enough time. Okay, so I shall move to close this meeting. Which we're at 12 o'clock. So what would we like to do in terms of coming back time?
One has to try. One has to try. Why don't we go for half 12, 21?
Week.
No, half 12, let's 12.
About 20. Let's come back.